Bonjour, bienvenue donc sur
Good afternoon and welcome
sur les
to this session on dual disorders.
donc je m'appelle Marc Auriacombe,
My name is Marc Auriacombe.
d'addictologie à
I teach addictology at Bordeaux University at the Charles Perrins Teaching Hospital. This is
ma collègue
co-moderated by my colleagues Laurence, Lalanne. I'm a psychiatrist and addictologist in Strasbourg. I teach psychiatry as well as in Strasbourg.
et donc nous avons
Strasbourg, so we have two presentations this afternoon. Let's start with the presentation by Christopher Jones. He's coming from Atlanta, or perhaps he's based in Atlanta. He's going to introduce himself, and then he'll give his presentation on opioids, overdoses,
l'état de santé
and psychiatric
dans le contexte
status
nord-américain.
in North America.
Christopher Jones, if you hear us.
Yes, I do.
Very good. And so the floor is yours.
Thanks very much. I apologize that I can't be there in person today, but happy to be presenting remotely. I'm Christopher Jones. I serve as the acting director of the National Center for Injury Prevention and Control at the U.S. Centers for Disease Control and Prevention, and happy to talk briefly today about the connections between opioids overdose, mental health, and suicide. Next slide. And briefly, I'll be covering just a very short recap of the state of the overdose crisis in the United States, which I think helps provide some framing for how we're approaching these issues. Discuss the intersection of opioid and other substance use disorders, mental health, and suicide. Describe the underlying mechanisms that contribute to risk for substance use and mental health, and then discuss some of the work that CDC is doing to address these interrelated and urgent public health issues. Next slide. And as I mentioned, I just wanted to provide sort of a brief overview of the current state of the drug overdose crisis in the U.S. And this is a figure that really just provides a bit of historical context for drug overdose death rates in the United States, looking back to 1968 through 2020. And you can see here that we have really had an exponential growth in overdose deaths during that time period. And I've labeled certain periods of time where there were particular sort of drugs of concern around overdose. So heroin in the late 1970s, crack cocaine in the 80s to early 90s. And then we see the sort of opioid era with prescription opioids in the late 90s. Then heroin, and then most recently, illicit synthetic opioids like fentanyl. And this is certainly the experience that other countries are starting to face as well. But we certainly have seen really historic levels of overdose deaths in the United States. And our latest data predict slightly more than 100,000 overdose deaths in the 12 months ending April 2021. It's about a 30% increase over the prior year. And we do believe that these increases are connected to the COVID-19 pandemic, but overdose deaths were increasing prior to COVID-19. But I think that they have accelerated during the pandemic, and certainly disruptions in access to care, increased stressors, mental health concerns among individuals due to the pandemic has contributed to the rise in overdose deaths. Synthetic opioids like illicitly made fentanyl are certainly the primary driver of increases in overdose deaths, but we are also seeing increases in overdoses involving stimulants, in particular methamphetamine and to a lesser extent cocaine. Next slide. And as I mentioned, the illicit synthetic opioids are really the primary driver, but we are seeing patterns of substance use change in the U.S. How drugs are being used is also changing, in particular with rising co-use of stimulants and opioids, in particular injection use. And we know that increases risk for adverse health outcomes like overdose and overdose death, as well as infectious disease transmission. We've also seen that in the U.S. drug market, the availability of highly potent illicitly manufactured fentanyl, or IMF here on the slide, has moved westward in the U.S., while methamphetamine has increased eastward in the U.S. And that confluence, along with proliferation of counterfeit prescription pills that are designed to look like commonly misused prescription drugs but contain highly potent illicit opioids, are really contributing to an unpredictable illicit drug supply and exposure among people who may not know the particular drugs or the potency of the drugs that they're using, which is really contributing to overdose risk. But relevant to the topic today, it's also important to recognize that co-occurring mental disorders adds to the complexity of our response to drive down overdose death rates and to treat substance use disorders, including opioid use disorders. Next slide. Now just talking a little bit about the intersections of substance use, mental health, and suicide. Next slide. And one of the areas that I've been particularly interested in my own research over the last few years is to really move beyond looking at substance use or mental health as sort of singular issues or one drug-specific issue like opioids or methamphetamine, but to recognize that people who are using substances or individuals who have substance use disorders are often using multiple substances, have multiple substance use disorders, and increasingly we document that there are co-occurring mental health challenges or mental illness among individuals. This slide is from research we did in a paper a couple of years ago that looks at a national survey done in the US each year by our Substance Abuse and Mental Health Services Administration, where we looked at the prevalence of co-occurring substance use and mental illness among adults with opioid use disorder. And you can see here, consistent with other research, that nicotine dependence and alcohol use disorder were the most common co-occurring substance use disorders among adults with opioid use disorder. But you can see here that large minorities also had cannabis use disorder, sedative tranquilizer, cocaine, as well as methamphetamine use disorder. I think what was particularly important about this paper was really documenting the high prevalence of co-occurring mental illness. And you can see here that having any mental illness in the past year was found among 64% of adults with opioid use disorder. And having a serious mental illness, which in this survey really captures significantly debilitating mental illness that disrupts everyday quality of life or productivity. About 1 in 4 adults with an opioid use disorder were identified as having serious mental illness. And I think it just really underscores the complexity. And from a policy or clinical practice perspective, I don't think we have historically appreciated that to really make progress on addressing opioid use disorder, we have to also put a system in place to address co-occurring substance use and mental illness. Next slide. We also found in the same paper that not only were co-occurring disorders quite prevalent, but in fact, there were many missed opportunities for treatment among adults with opioid use disorder. We found that about 38% of adults with opioid use disorder received any substance use treatment in the past year. Among those that had both opioid use disorder and any mental illness, as well as those with opioid use disorder and serious mental illness, you don't really see any better receipt of treatment for substance use disorder, still right around 38%. When we looked at mental health treatment, we do a little bit better. You can see here about 55% of adults with opioid use disorder and any mental illness received mental health treatment in the past year, and about 2/3 of those with opioid use disorder and serious mental illness received mental health treatment in the past year. But I think the findings are even more concerning when we look at whether or not individuals receive both substance use disorder treatment and mental health treatment in the past year when they had a co-occurring opioid use disorder and mental illness. And you can see here about 25% with OUD and any mental illness received both, and about 30% for OUD and serious mental illness received both in the past year. So again, great opportunity to improve treatment access and the provision of treatment. I think one of the other important takeaways from this research is that even though individuals who had mental illness and opioid use disorder were more likely to receive mental health treatment, they were not more likely to receive substance use treatment, which is interesting because they were having touch points with the healthcare system in that they were receiving mental health treatment, but were not necessarily more likely to receive substance use treatment. So obviously that adds to the complexity of addressing the underlying mental health condition if we're not addressing co-occurring substance use and vice versa. Next slide. We also see the implications of mental health play out among overdose deaths. These are data from a CDC surveillance system that captures drug overdose death information from the majority of states in the United States. And you can see here that there are a number of contextual factors that are prevalent among people who are dying from drug overdose. And this is broken out by different types of drug involved. But what you see here overall, about 25% of individuals who died from a drug overdose had a known mental health diagnosis. And you can see, there are other factors like recent release from an institution or prior overdose or ever receiving treatment for substance use disorder that are also missed opportunities for engagement or risk factors for overdose. And I would say that this is certainly an underestimate of mental health diagnoses, but this is known mental health diagnoses. So clearly it does have interplay with overdose risk. Next slide. We also see a connection between prescription opioid misuse as well as illicit opioid use and suicide. This is from a recent paper we did among high school students in the US, looking at the relationship between prescription opioid misuse and suicide. And you can see here that across the various outcomes that we looked at, seriously considering attempting suicide, made a suicide plan, attempted suicide, or felt sad or hopeless, individuals who had ever misused prescription opioids, and in particular, those who were misusing prescription opioids in the past 30 days had elevated risk for those suicide-related outcomes, even after controlling for sex, race, ethnicity, what grade they were in, sexual minority status, and other substance use. So again, I think it underscores just this connection between substance use, mental health, psychological distress, that there are many shared risk factors, but also shared protective factors as we think about how do we address these issues. Next slide. Now moving into some of our how we're approaching thinking about prevention and some of the underlying mechanisms that contribute to increased risk for substance use and mental health. Next slide. So at CDC, we have long been interested in childhood trauma, or what we often term as adverse childhood experiences or early adversity in life. And this concept of adverse childhood experiences comes from work that CDC did in the mid to late 1990s, where we were trying to understand how the events that happen early in life contribute to later health outcomes, like chronic diseases, early mortality, and engaging in health risk behaviors. And traditionally, we have defined ACEs as physical, emotional, or sexual abuse, physical, emotional neglect, and then growing up in a household that has particular household challenges like mental illness or substance use in the home, witnessing domestic violence, having an incarcerated relative or family member, and then divorce of parents. But as the science has matured, we recognize that there are other events that happen to young people, especially in the early years of life, that can play out very similarly to the more traditionally defined ACEs. So things like bullying, teen dating violence, peer-to-peer violence, witnessing violence in your community or at school, experiencing homelessness or death of a parent, regardless of the cause, can be traumatic experiences that have implications throughout the lifespan. And in the US, we estimate that about 61% of adults have experienced at least one ACE, and about 1 in 6 have experienced 4 or more ACEs. And the cumulative effect of ACEs, I think, are important, which I'll show in a couple of slides. We also know that exposure to adverse childhood experiences are not evenly distributed across the population in the US. We tend to see higher prevalence of ACEs among communities of color, people who have lower education or socioeconomic status, as well as members of the LGBTQIA community as well. Next slide. And we have about 20 years of research that shows a strong connection between adverse childhood experiences and a variety of health outcomes, including increasing risk for depression, anxiety, other mental health conditions, maternal health, infectious disease, health risk behaviors like substance use, chronic disease, and leading causes of death, as well as economic and job opportunities. Next slide. So how is it that these events in early life have effects throughout the lifespan? And I think fundamentally it comes down to the systems in the brain that can be exposed to stress-related chemicals, and that, you know, stress is certainly a normal part of development, but when people are sort of repeatedly exposed to stressful events like child abuse and neglect, or instability in the home, or uncertainty or unpredictability in their environment, toxic stress can accumulate and have detrimental effects on multiple brain circuit systems, especially how the brain and body respond to stress, how we process rewards and emotions, how we deal with coping strategies, and ultimately how our executive function, decision-making, cognition systems develop. And so you can see here, both for mental health as well as substance use, if you think about dysregulation of the neural networks for how we process emotions, or how we receive and understand rewards, or how we cope with stress, I think there's a clear-cut case that if we could reduce exposure to toxic stress and its cumulative effects, there's a real opportunity to reduce substance use or mental health challenges. Next slide. Specific to substance use, this is from the original ACEs study conducted by CDC, where they looked at the cumulative effects of ACEs. And you can see here, this is exposure to 1, 2, 3, or 4 or more ACEs, and risk for current smoking, alcohol use disorder, ever using illicit drugs, or ever injecting drugs. And you can see here a pretty clear dose-response relationship in that the larger number of ACEs that someone is exposed to, the greater their risk for engaging in substance use, really regardless of how you define that substance use, including more commonly used substances like smoking, all the way through less prevalent illicit drug use or ever injecting drugs. And there's reams of research that have documented this in the context of other substances, but for the interest of time, I'm just sort of presenting this as a summary to reflect the literature that's out there. Next slide. And specifically looking at opioids, as well as illicit opioid use and prescription opioid misuse, this is a recent study among young people in New York City where they looked at the prevalence of ACEs. And you can see on the left-hand side different types of ACEs that someone was exposed to. You can see here, again, pretty high prevalence among people who are using opioids. But what they found is that for each additional ACE, individuals were more likely to engage in opioid use behaviors at an earlier age, including higher risk behaviors like injecting or snorting opioids. And you can see here that really 90% of individuals among this cohort had experienced at least one ACE, and almost 50% had experienced 4 or more ACEs. So again, it sort of underscores the potential impact of ACEs and the opportunity for prevention as we think about how do we get upstream to reduce risk for substance use and substance use, mental health, and related harms. Next slide. Similar to substance use, we also see the same connection between exposure to ACEs and suicide risk. This is just one study that looked at the number of ACEs as well as different types of ACEs and their relationship to suicidality. And again, you can see here the dose-response relationship. As the number increases, you do see a stronger increase in risk. But really, regardless of what type of ACE, you do see increased risk for suicidality. Next slide. And I think the good news is that while we know that ACEs contribute to increased risk, it's not inevitable that ACEs will contribute to risk for substance use and mental health if policies, practices, programs are put in place to mitigate or blunt the effects of ACEs. And this is just an example of a research study that looked at some protective factors against psychological distress or substance use problems, even among people who had exposure to ACEs. And what this study found is that protective factors like resilience, family communication, school connectedness, having peer role models, and a non-parental adult role model were all important protective factors in reducing the effects for psychological distress or substance use, even among individuals who had high exposure to ACEs. And I think this sort of lends itself to, okay, so if we know ACEs can contribute to risk, what are the things that we can do to mitigate those impacts? Next slide. Next slide. And at CDC, as we think about an environment of declining mental well-being, increases in mental health stressors and mental health concerns, and certainly rising overdose death rates, there is a need to focus on harm reduction, recovery services, access to evidence-based treatment, intervening as early as possible, and continuing to understand the evolving overdose crisis. And those are all really critical activities, but it is equally important that we really think about the long-run strategy and focusing on upstream prevention with a particular focus on preventing adverse childhood experiences as an opportunity to reduce in the long run the number of individuals who are engaging in substance use or have substance use related harms or mental health challenges. Next slide. And at CDC, we have sort of operationalized the idea of ACEs prevention within a resilience framework and really thinking about what are the things at the individual, family, community, and society level that can be done to instill resilience. And from a very broad perspective, that includes safe, protective, and equitable environments, presence of positive relationships, and then healthy development of social and emotional competencies. And as we think about addressing ACEs, we have to tend to not only the more traditionally defined ACEs, which are really at the individual or interpersonal level, but also the context in communities that contributes or exacerbates ACEs, like housing and food insecurity, lack of opportunity, violence in the community, discrimination, longstanding poverty. All of those factors certainly contribute to the disproportionate burden of ACEs. Next slide. And we have released a prevention resource that distills down the evidence base and really provides a roadmap for preventing ACEs with the aims of, again, creating the conditions for strong, thriving families and communities where children and youth are free from harm and all people can achieve lifelong health and well-being. And our evidence-based policies, programs, and practices fit within 6 primary areas. So strengthening economic supports for families, promoting social norms that protect against violence and adversity, ensuring a strong start for children, enhancing skills to help parents and youth handle stress, manage emotions, and tackle everyday challenges, connecting youth to caring adults and activities, and intervening to lessen immediate and long-term harms. In the interest of time, I won't go through each of those, but there are specific policy levers, programmatic interventions, or clinical practices that fit within those 6 areas that, if done and implemented, have a real potential to reduce ACEs and their long-term impacts. Next slide. And I just want to highlight 2 particular programmatic interventions that are part of our strategy for preventing ACEs. And the first is the Nurse-Family Partnership, which is a program that essentially connects an expectant mother or family with a nurse through in-home visitation, really for the first 2 years of life, from during the pregnancy up to the first 2 years of life. And it's really a parenting skills program, helping parents understand how critical those first few years of life are, how to be successful, address questions and concerns, and getting parents ready to be parents. In long-term randomized controlled trial studies, the benefits of this type of intervention have been well documented, including a paper that looked at a 15-year follow-up period among women who were exposed to the program had reduced behavioral impairments from substance use. They also had reductions in other social, criminal justice, and health harms. So there was a benefit to the pregnant woman who was exposed to the program, but equally important, a longitudinal study that looked at the kid of the woman who was exposed to the program when the kid was 12 years old found that they had fewer days of alcohol, cigarette, and marijuana use, also had reductions in mental health conditions and improvement in academic outcomes. So again, an intervention that ends at the 2nd year of life for that kid had lasting protective effects for both mom and child. We also see similarly lasting effects from social emotional learning programs among youth. And these are programs that are really designed to help kids handle stress and emotions, conflict. And examples are things like life skills training, strengthening families, raising healthy children, where these interventions might be implemented in elementary school or in middle school. But they're really focused on resilience and social emotional learning skills. But again, rigorous research has found that when these programs are appropriately implemented, they can reduce substance use across a range of substances, even into young adulthood, despite the intervention being provided when kids are 10, 11, 12 years old. A recent study also found that there were multi-generational impacts of the Raising Healthy Children program, which is, again, sort of a school parent-based intervention, that the kids of parents who were exposed to the intervention when those parents were in school, their kids actually had reduced substance use and other high-risk behaviors, showing some spillover effect to the next generation. So I think, again, it underscores that as we are trying to think about how do we get ahead of substance use and mental health challenges, there are opportunities to think upstream and to really put a focus on prevention to reduce the long-term impacts of these quite challenging public health issues. Next slide. Just briefly, next slide, I'll talk about what CDC is doing, and this is probably more for a domestic US audience. But at CDC, we have about $1 billion program called Overdose Data to Action, which is providing funding to almost all states, as well as large cities in the US, to implement overdose prevention efforts. We also have a number of other programmatic efforts at the local level that are implementing overdose prevention, which includes things like linkage to care services, harm reduction, as well as upstream prevention like ACEs prevention activities. Next slide. We also have a program that funds 6 jurisdictions specifically focused on preventing adverse childhood experiences. And this is called Preventing ACEs Data to Action. And it is helping to support both improve surveillance systems to identify and understand ACEs in the impacted populations in those states, as well as to implement from our evidence-based list of programs, policies, and practices, strategies that can reduce ACEs in the population. So this is a program that has just started about 2 years ago, and certainly there is a great need for expansion of that program. Next slide. And just to wrap up, I think just a couple of points. In the US, we continue to see an evolving overdose crisis that continues to escalate. This is largely driven by an unpredictable illicit drug market and changing substance use patterns. We continue to see in our surveillance data, in our analysis of overdose deaths, that there are many opportunities that are missed to connect people, provide people with treatment for substance use disorders, opioid use disorders, as well as co-occurring mental disorders. And this really adds to the complexity of our response. And as I mentioned earlier, it is absolutely critical that we expand access to treatment, recovery, and harm reduction services, but equally essential that we focus on evidence-based prevention policies, programs, and practices. And based on the totality of the evidence base and the potential for profound public health impact, focusing on ACEs prevention is a real opportunity to change the trajectory of substance use, mental health, and overdose in the US. So thanks very much for the opportunity to present. Happy to answer questions when the time is right.
Thank you, Dr. Jones. Is there any question in the room? No? I have one question. Did you, I asked my question. Did you quote the severity of traumatic exposure of people who were engaged in the cohort? Of traumatic exposure in childhood or in adulthood? Did you see any difference in their opioid use?
Yeah, we do see that individuals who have been exposed to higher numbers of ACEs are more likely to have opioid use disorder or polysubstance use disorder or use substances in higher risk ways, like so more likely to inject compared to individuals who either had fewer exposure to ACEs or no exposure to traumatic events. And that's pretty consistent across most substances. We recently did an analysis looking at stimulants and stimulant use disorder, and you see something very similar, that those who have higher numbers of ACEs are more likely to have a use disorder, we're more likely to start using substances at an earlier age, which we also know is associated with higher risk use patterns as well.
Yeah. Thank you.
This is working. Thank you for your presentation. It was really great. I wanted to ask, You presented a graph where you showed the different waves of the uses of opioids in America, going from heroin to crack to synthetics. Do you see a similar pattern happening in any other parts of the world where there are different waves and different substances being misused?
Yeah, I think that probably Canada and Australia are most similar to our experience in the US, where there was clearly a period of time in the late 90s, 2000s, where prescription opioids were contributing to overdose deaths. And then you start to see heroin and then more recently fentanyl. I would say maybe less fentanyl in Australia. Certainly Canada's experience is similar to ours. But then also more recently a rise in methamphetamine that we're seeing in those jurisdictions. I think in the EU, from what I know of EMCDDA and other reports, there are changing patterns, but I don't know that the escalation in overdose deaths looks similar to ours. I think there are certain countries that have been impacted by fentanyl over the years, like Estonia, which probably saw a steeper overdose death curve than some other countries. But I would say for us, Canada certainly is the one that is most comparable, and Australia has some similarities as well.
Thank you, Dr. Jones, for the clarity of your presentation and of your response. We will move to the next presentation, and it's Icro Maremmani who will present dual disorder in opioid patient, clinical and therapeutic aspects. So it's up to you.
Thank you very much for inviting me to this Congress. And the title of my today presentation is a question: bipolar depression in dual disorder patients or dual depression in depressed heroin addicts without a dual disorder? It's not easy to answer this question. First of all, I want to say that WADD was born to spread the new paradigm in neuroscience, to understand a new mental health. The psychiatry of the future cannot fail to be an expert in dual disorder, because the frequency of these patients has already reached 50% and, in my opinion, will increase in the coming years. But above all, WADD was born to avoid a syndrome that was widespread in the past. In those countries where addiction and psychiatric service were separate and often distant each other, sometimes in open opposition. What can happen when these services do not communicate each other? It is the so-called wrong door syndrome, in which the psychiatrist who finds cannabis use in a psychotic patient often tries to transfer him to the addiction unit, or, unable to make a diagnosis, does not prescribe the drugs correctly. This is the description of a wrong door syndrome in Slovenia, where psychiatric and addiction units are separated as in Italy. In this study, if patients during a methadone maintenance therapy reported depression, anxiety, somatization that is a sign of withdrawal symptoms, or psychotic symptoms, psychiatrists prescribed antipsychotics and benzodiazepine. If, after methadone maintenance, patients reported depressive symptoms, psychiatrists prescribed antidepressant. No indication for medication-assisted rehabilitation with methadone or buprenorphine is generally provided by psychiatrists who, almost in Slovenia, but probably in other parts of the world, were not able to recognize heroin use disorder patients and their possible symptomatology during and after a methadone treatment. But we must return to the first question. When depression is present in dual disorder patients, we are facing a bipolar depression and a dual depression in substance use disorder patients is really existing. This slide is what we knew in the past. On the left is the frequency of a major depressive episode according to the DSM criteria at various stages of the disease. 50% in the street, 34% at the treatment entry, and during treatment in therapeutic community, 46%, and 23% as index episode in methadone maintenance, and from 50 to 70% in methadone maintenance lifetime. But note that during methadone tapering, 62%, and after methadone tapering, 25%. On the right is the type of depression. Excluding a few cases with atypical depression, most cases were classified as a major depression according to the DSM criteria. Bipolar depression was very rare, at least until our studies, in which bipolarity reached 50%. These are our first patients admitted to the Santa Chiara Hospital, University of Pisa. As you can see, bipolarity is more frequent than unipolarity, which is not surprising because severe depression and mania almost always require hospitalization. But in heroin addicts, bipolar 1 patients are more represented. In our clinic outpatient setting, on the other hand, unipolar and bipolar patients were equally represented, but the bipolars at this time were almost fully bipolar 2, therefore with hypomanic characteristics. Then we also considered familiarity with the psychiatric disorder and the presence of an affective temperament. Only 1 out of 40 consecutive patients did not have a relationship with bipolarity, called, in this case, bipolar spectrum. The homonyms are certainly homogeneous from a psychosocial point of view, but even in this case, it is bipolar depression that is correlated with increased substance use, especially opioids and stimulants. It is the use of speedball that characterizes bipolar depression. What we have said so far convinced us that we had to go towards a unitary perspective on the bipolar spectrum and substance use disorder. And so we have shown that the affective temperament, especially in its irritable cyclothymic form, characterizes heroin addicts, and in the depressive cyclothymic form, alcoholics. We have also shown that these characteristics do not depend on the presence of a dual disorder. We have also shown that the polyuse, especially of stimulants and sedatives together, is related to bipolarity in both heroin addicts and alcoholics. The impulsivity of patients with substance use disorder is also linked to bipolarity, both violence and suicidality. Therefore, a strong impulsive disposition is found in patients with the dual disorder. Still, we will see shortly that the violence and suicidality is also found in patients who do not have a dual disorder. We think that this dimension, together with the depressive one, characterize the specific psychopathology of substance use disorder. Sorry, but I need... In addition, bipolar depression is also characterized by increased use of social drugs like tobacco and coffee, but not for chocolate. In this study, bipolar heroin-addicted patients were chosen because they tend to have polysubstance use and because they more clearly reveal a variety of affective states, from hypomania, mania, mixed state, and depression. As you can see, patients with a depressive episode more frequently use non-prescribed benzodiazepine. They were found to use stimulants more regularly during an hypomanic episode, whereas cannabis and stimulants occurred more frequently during a manic episode. The co-use of alcohol, stimulant, and cannabinoids was more frequently during a mixed episode. This study supports the hypothesis that mood elation is a pleasurable and a rewarding experience that in bipolar patients can be started or prolonged using stimulant drugs. Therefore, stimulants use was more prevalent during the up rather than the down phase of the illness. Finally, I want to propose a possible trajectory of substance use in which the bipolar spectrum could play an important role. In the case of bipolar heroin addicts not adequately treated for their opioid addiction, these patients may resort to alcohol in addiction to or after stopping heroin use. Finally, they can also use cocaine when their mood condition becomes tendentially depressive. Therapeutically, bipolar 1 patients require special treatment with opioid agonist medication. In other words, the bipolar depression and or mania in heroin addicts need an opioid medication adjusted treatment. Opioid medication must be used at over standard dosages. Why over standard dosages of methadone or buprenorphine are needed in bipolar 1 heroin addicts? Because we must control full cumulative levels of opioid death. The first opioid death is related to the severity of illness in the street, the level of tolerance to opioid in the streets. The second level is the eventual presence of a pain syndrome. In this case, the dosage must be increased, not reduced. The third level is due to the presence of a psychopathology, due to the presence of a dual disorder, but also to the presence of a psychopathology specific to substance use disorder. The fourth level is due to the presence of stress. Consider that generally heroin addicts show a reduction in the resistance to stress, and that we have demonstrated a sort of post-traumatic stress disorder spectrum, an heroin post-traumatic stress disorder spectrum in many heroin addicts regarding their normal life events. Should depression be considered always a dual disorder? As you can see, a depressive anxious syndrome is dominant at the treatment entry, but poorly correlated on the right part with the presence of a concomitant dual disorder. What is the reason for this so frequent depression not related to a dual disorder? We think it's because our patients are addicted. The only one psychiatric illness without a specific psychopathology, only in presence of another. psychiatric illness we consider a psychopathology for drug addicts. This is not true. And 10 years ago, we discussed the problem of the existence of a specific psychopathology of drug addicts, supporting the evidence that anxiety, mood, and impulse discontrol must be included in the diagnosis of drug addicts, not only craving and relapse. We are convinced that a specific psychopathology of heroin addicts do exist. In drug addicts, we have not 9 dimensions as in the other psychiatric patients. We have only 5 dimensions: worthlessness, being trapped, somatic symptom, sensitivity, psychoticism, panic, anxiety, and violence, suicide. Worthlessness, being trapped, is representative of a dual depression. Somatic symptom is very similar to an opioid withdrawal syndrome. Violence suicide is representative of impulse discontrol, as we have supposed in our first paper. Sensitivity psychoticism, especially sensitivity, can represent in part the patient's reaction to the stigma for drug addicts in general population, and panic anxiety is probably related to the presence of opioid receptors in the locus coeruleus, that is the center of panic attacks. All that remains to check is if the depression of drug addicts is like that of all other depressed patients, or if it is a specific depressive variant. On the other hand, we already know about the depression or depressive syndromes of drug addicts. The reward deficit syndrome and the post-withdrawal syndrome are 2 conditions in which the mood is depressed, but in which there are not all the diagnosis criteria of the major depressive episode. This slide shows that the first symptoms that make up the worthlessness being trapped factor are depressive, really depressive. Then other symptoms appear that generally belong to different diagnostic groups, such as obsessive compulsive, sensitive psychoticism, and anxious symptom. It must be remembered that the symptoms, feeling low in energy or slow down, thoughts of ending your life, and crying easily, that are depressive in depressed non-addicts do not belong to depressed addicts. So, not finding this symptom does not mean that the patients are not depressed. Comparing depressed heroin addicts with the non-depressed ones and depressed non-drug addicts, we can see that the typical symptoms of depression are more frequent in depressed non-drug addicts ones. At the same time, in depressed heroin addicts, the predominant symptoms are non-depressive when compared with the depressed non-drug addicts, and depressive on the left when compared with the non-depressed heroin addicts. Note that worrying too much about things is a depressive sign distinguish non-depressed heroin addicts from depressed ones. More precisely, the item that distinguish the depression of heroin addicts from the depression of depressed non-drug addicts can be grouped into 2 dimensions. One of mood reactivity sensitivity, and the one of psychasthenia, OC. To understand the origin of the latest 2 dimensions, you must consider the cycle of addiction and the outcome of addiction. The illness is characterized by the alternance of intoxication and self-detoxication, with a progressive loss of the capacity to be rewarded by all normal pleasant activity, only the substance used. So, at the end of the natural history of the illness, the anhedonia is dominant. We are convinced that the worthlessness being trapped dimension is the sum of depressive symptoms with the negative symptoms representing the outcome of addiction. Post-withdrawal syndrome, hypophoria, deficit reward syndrome, and a motivational syndrome. So, dual depression is characterized by the co-presence of standard depressive symptoms and symptoms due to the outcome of addictive process. And this depressive symptomatology is due to the addiction and not to the presence of a comorbidity disorder, psychiatric disorder. In fact, we did not find differences between non-detoxifying and detoxifying addicts at therapeutic community entry, among alcohol, heroin, and cocaine addicts, among heroin addicts with the secondary use of alcohol or cocaine, among alcohol, heroin, and cocaine mono user. It's rare to find, but it's possible if we treat thousands of people. Between heroin addicts with the psychiatric comorbidity and without psychiatric comorbidity, and between migrant and Italian heroin addicts, or between Slovenian and Italian heroin addicts. In the right part of the slide, you can see a curiosity. How we decide the type of the treatment according to the gender of our patients. More severe depressed male are generally treated with methadone or buprenorphine, but more severe depressed women are treated in therapeutic community, almost in Italy. Gender stigma for opioid medication or what? The last slide is to show you the impact of psychopathological subtypes on retention rate of patients with the substance use disorder. It's possible also for agonist opioid treatment, but it's possible to have an answer also for people in therapeutic community. Please notice how cocaine addicts are the subject who get the worst results in therapeutic community. On the contrary, alcoholics get the best results, almost in Italy. Subjects who show predominant symptoms of worthlessness being trapped at therapeutic community entry seem, at least at first, to have the best results. At the end of my presentation, I want to show you what is the destiny of the specific psychopathology of substance use disorder during an agonist opioid treatment program. After 30 years of opioid medication treatment, psychopathology remain at minimal levels, and no more patients are dominant in worthlessness being trapped. But if we consider the destiny of the heroin post-traumatic stress disorder spectrum, you can see that out of 7 patients treated for more than 20 years, only 2 were without the presence of this kind of spectrum, whereas 4 patients were still symptomatic. Please note that one patient, after a long period of treatment, is still taking a dose of opioid medication, around 30 milligrams of methadone, continued to present a severe spectrum post-traumatic stress disorder spectrum. This patient was completely rehabilitated regarding his social adjustment and was not using any kind of illegal substance for long times. Concluding, So far, I can say that depressive symptomatology in heroin addicts is related or to the presence of a dual disorder or is the psychiatric consequence of addictive processes, craving, and relapse. And we have the treatment implication. The bipolar depression in heroin addicts need an opioid medication adjusted treatment, and in all patients, the agonist opioid treatment should not be terminated in responder patients when dual depression is still predominant. The clinical implications are that in dual disorder patient, depression is a bipolar depression, and in non-dual disorder patients, we must consider a special variant depressive syndrome that we can name dual depression. Thank you very much for your attention.
Thank you, Icro, for this excellent presentation, as usual, and for being right on time, and for being able to catch up, because you had the General Assembly of the WADD Association that was this afternoon. On a le temps pour quelques questions.
We have time for a couple of questions.
Donc, levez la main pour quand même.
Please raise your hand if you have a question. You will be given a microphone.
To start as an initial question, Icro, you document very well that psychiatric symptoms in dual disorders and in people with opioid use disorder should be treated first with optimal dosing of methadone or buprenorphine, of agonist treatment.
Yes.
And so at what moment would it be appropriate to introduce, because of the bipolar spectrum in dual disorder, what's the right time to introduce a lithium or equivalent in relation to methadone and buprenorphine?
Yes. The problem is that generally bipolar depression is not a good idea to treat this kind of depression with antidepressant because the risk is a switch in manic episode that in heroin addicts is a stimulus to increase the use of substance of abuse and not to reduce. And in our experience, the priority of the treatment is related with the addiction. And we must control the addiction first. And then, if this is not sufficient, we can introduce, but in our opinion, only stimulants, antidepressant are better, dopaminergic and noradrenergic substances, because the risk is that in long time there is the presence of the hypophoria in all patients, and the hypophoria plus depression need something prodopaminergic. At the end of a methadone treatment, for 6 months after the end of the treatment, we use dopaminergic antidepressant to reduce the possibility to have a relapse because of the hypophoric symptomatology that can remain after the end of methadone or buprenorphine treatment. But I think that the news is that we must first treat the addiction and then the psychiatric comorbidity. Lithium is good, is really good, but it's difficult to use lithium in people with addiction because we must be compliant to some rules. And valproic acid is better, that is more safe. Carbamazepine is good for temporal symptomatology, but reduce the methadone blood level. So we must pay attention to use carbamazepine and oxcarbamazepine. But our treated patients with a higher level of methadone were co-treated with acid valproic that do not interfere or interfere minimally with opioid level in the blood. But it's a little bit complicated.
Right, it's a tricky issue. But the bottom line is really treat aggressively the addiction and optimize methadone and buprenorphine treatment.
Yes, yes, almost for heroin addicts. The problem is different with the people non-heroin addict. I think that heroin addiction is the border of the modality of treatment of depression. If there is heroin addiction also in the past, it's better to return to the opioid medication and increase the dose of opioid medication. If there is no heroin addiction, is another history.
Right.
Christopher, thank you. Thank you so much, both of you, for your presentations. Outstanding presentations, and I am very grateful